Disparities, the intersection between pediatrics and public health. Before we begin, I'd like to discuss a few general housekeeping rules. If you encounter any technical difficulties during today's webinar, please make a note of the 2 telephone numbers listed below. GoToMeeting Corporate Account Customer Support can assist you. We are recording today's webinar, and the slides will be made available after the webinar as well. You may submit any questions that you have throughout the webinar. You should have either a question or a chat box, and I will see those as they come in, and then we will accept Q&A at the end of the presentation. I also would like to tell you a little bit about the Hopkins Center for Health Disparity Solutions, since we are co-sponsoring today's webinar. Our center was founded in 2002 by Dr. Thomas LaVeist. We are a center of excellence in minority health and health disparities funded by the National Institutes of Health, the National Institute on Minority Health and Health Disparities. So we are very committed to helping to produce webinars on these types of topics. And now I'd like to turn this over to my colleagues, Dr. Jackie Dougé and Amaka and Nwankwo-Igomu.
Thank you, Cheri. Welcome everyone to today's webinar. Again, as Cheri Wilson mentioned, my name is Jacqueline Dougé, and again, I want to welcome you. Next slide, please, Cheri. So I wanted to just give some background as to how this webinar developed. The three of us, Cheri, Amaka, and myself, formed together the Pediatric and Public Health Group of Maryland, and it was born out of the desire for us to address and eliminate child health disparities and to collaborate with colleagues, other organizations, and stakeholders seeking to improve the health of children in Maryland. Next slide, please. The purpose of today's webinar, these key points that we want to cover are providing an overview of child health disparities and its impact, presenting data over the lifespan from birth to adolescence, discussing how healthy are Maryland's children, and identifying stakeholders that are addressing the challenges of childhood disparities. Next slide, please. So we're focusing on the lifespan in today's webinar. And the reason why we're focusing on the lifespan is that we decided that most people, when they address childhood disparities, tend to only focus on one sector of childhood, either adolescence or early childhood disparities. And during the lifespan, there are critical and sensitive periods throughout the life, there are cumulative risks that develop, and it's becoming a newer approach to addressing health disparities. Next slide, please. So in general, poor health in childhood impacts adult health. And again, just reiterating the fact that children experience health disparities throughout their childhood, from infancy to adolescence. And there are also important social determinants of health that impact the health and well-being of all children. Next slide, please. Today's webinar focuses on data for the health status of Maryland's children. And we wanted to focus on data today because it helps to determine current status of children's health and possible future threats. In addition, it helps us to determine where to focus resources, and it also helps us to identify gaps in current research regarding childhood disparities. Next slide, please. And I thought this quote just summed up the purpose of today's webinar so well. It was taken from the DC Baltimore Research Center on Child Health Disparities Writing Group, and as stated in the slide, the future health and well-being of America is linked to how successfully we manage the health and well-being of today's children. And next slide, and I will turn it over next to Amaka.
Good afternoon, everyone. Our next purpose is to focus a little bit on health disparities. Again, as Jackie said, my name is Amaka Nwankwo-Igomu, and I will provide some information before turning it over to our additional stakeholders who will give us some of the data. Next slide. Next slide. Thank you. So you know what health disparities are. Many of you, we would imagine, that are joining because you come either from the public health sector or from an arena addressing health issues, including disparities. But just as a basic definition, we want to recall that these are the differences in health outcomes that are closely linked with social, economic, and environmental disadvantages. And they're often driven by social conditions in which individuals live, learn, work, and play. The first report on health disparities was actually generated through the Surgeon General's office by Dr. David Satcher, where he observed culture and used culture to broadly define a common set of beliefs and norms and values that impact mental illness and mental health in this initial report in 2001. It influences, either for better or for worse, how patients and clients communicate and manifest their symptoms and how they cope, the range of their family and community supports, as well as their willingness to seek treatment and engage in the healthcare system. The first legislation on health disparities created the National Center for Minority Health and Health Disparities within the NIH, and there's a web link that will be provided to you once the slides are provided. Next slide. The Office of Minority Health leads Health and Human Services, the Department of Health and Human Services, and health disparities, especially related to an action plan that was developed recently for the nation to address mostly racial and ethnic disparities. The Health and Human Services Disparities Action Plan commits to continuously addressing the impact of all policies and programs on racial and ethnic health disparities and promotes integrated approaches, evidence-based programs, and best practices and lessons learned to reduce these disparities. The national report again focuses on prevailing racial and socioeconomic disparities in healthcare delivery in priority populations, which are defined within the report. In addition, the National Prevention Council, which also comes out of the Surgeon General's office, published a strategy on the elimination of health disparities in 2010 that provided recommendations at all levels of government and within societies and other partnerships, including businesses, communities, individuals, and families. So at every level, the responsibility to eliminate health disparities is addressed in this particular strategy. Next slide. So together, addressing the lifespan and health disparities, you know that most health disparity reports focus on the adult population, hence wanting to address this in the pediatric and youth population. There was a Center for Disease Control and Prevention report in 2011, and those measures included children, but they mostly only address infant mortality and preterm birth, asthma prevalence, as well as adolescent pregnancy and childbirth. So we know there are several factors, especially the socioeconomic factors that I mentioned earlier, that impact the health of children, including their education and some of these other measures here. And this is what we hope to address a little bit further within today's webcast. Next slide. And we felt that this quote more or less speaks to where we're getting in terms of health disparities. And poverty is not an accident. Like slavery and apartheid, it's a man-made and can be removed from the actions of human beings. And so that's hopefully what most of you joined to try and attempt to address in your day-to-day work. And hopefully today's information will only impact that and allow us for further discussion in the future. We know the world of childhood disparities is unacceptable, and the way to begin and move forward is to create some change. So that's our goal again for today. And with that, I'll turn it over to our moderator, Ms. Wilson.
Great, thank you, Dr. Dougé and Amaka. And now I'd like to turn it over to, and of course, these are just pictures of the three of us from the Pediatric and Public Health Group of Maryland, Dr. Jacqueline Dougé, Amaka Nwankwo-Igomu, and myself, Cheri Wilson. Now I'd like to turn the presentation over to Dr. Diana Fertsch.
Good afternoon, everyone. It's so great to see such a wonderful turnout for our first webinar. Hopefully there'll be many more. So I'm going to speak to some of the pediatric issues in this whole childhood healthcare disparities dialogue. And I am a pediatrician from the Dundalk area. I practice at Dundalk Pediatrics. Next slide, please. And I completed medical school not far from Dundalk, just at Hopkins, and pursued my residency in pediatrics at the same institution, and unfortunately didn't wander very far after that. I joined practice in Dundalk immediately following residency because I was very attracted to its deep roots now, having served the community for over 45 years. And it had and continues to have a very diverse ethnic and socioeconomic community. Over 15,000 patients are served in our office, our practice, and over 2/3 of them are publicly health insured through Medicaid. We have a great base of pediatric providers, and currently we have 5 pediatricians, 3 pediatric nurse practitioners, and a physician's assistant. And I think that although we're a private practice, we were kind of innovators in adopting an electronic record over 10 years ago to help manage some of the paperwork that flows in and out of a busy practice. And shortly after that, we hired a care coordinator to manage some more of the complex medical cases that we were seeing, and most recently hired a nurse educator to deal with some of the kind of chronic medical challenges in pediatrics, namely asthma and obesity. Next slide, please. So we've really, at a very basic and holistic way, have embraced early childhood identification of prenatal and postnatal risk factors for our families and our children. As I said, we are often seen as the practice that never says no to tertiary care centers, so we'll take anybody from a micro preemie at 24 weeks to a child who's technology dependent with a vent and a trach and who may need home visits. We do screening of all children at all well child visits, whether it's the autism screening that's appropriate at certain ages, or the ages and stages questionnaire that's appropriate over the earlier years. And we also do a kind of a early teen screen for older kids as well. And we're well versed at kind of where to refer these patients when their trajectories kind of take a turn off the norm. I'm very proud of 2 programs in our office. My partner, Heather Wade, brought in a program called Reach Out and Read, which is a program that kind of reinforces early literacy, and every child between the ages of 6 months and 6 years of age gets an age-appropriate book, and parental coaching about the value of reading to their child and encouraging their child to pick up books. And the other thing that we've had in our office for about 5 years is a parent support group for families dealing with ADHD in their children, sponsored in part through an organization called CHAD, Children and Adults with ADHD. And it really is to help families get educated about ADHD and become better advocates for their child. Next slide, please. My other hat is that I am the current Treasurer Secretary of the Maryland chapter of our organization, professional organization called the AAP, or the American Academy of Pediatrics. And I just really wanted to show you that the goals that we're talking about today and the challenges are very much in alignment of kind of the national organization's kind of goals and principles. And if we look kind of at the big circle that kind of envelops all of the smaller pillars and boxes, we can see that the AAP is committed to health equity, medical homes for all children, and supporting the profession of pediatrics for all pediatricians, but definitely for the 60,000 members nationwide and internationally. The pillars are kind of the game plan for access to health care, quality health care, highest quality, and appropriate financing of health care. And the priorities which fit in these boxes on top of these pillars, you can see that the first one, the top priority of poverty and child health is current poverty, is a current agenda item for this year in its planning phase. So we can kind of look to the leadership in this organization to support us as well. Next slide, please. So rather than sit here and talk about pillars and boxes and kind of the whole kind of framework, I'd like to introduce a patient, which is kind of in the kind of what I do every day of my life. As I see patients, and I try to identify risks and unmet needs and connect these patients to services. So this is a patient whose name has been changed. He's, we'll call him Seth. He is a real life patient with a real life story. I saw him this fall, 2 days after a concussion for which he went down to Hopkins and was observed for significant head trauma. He was jumped and slammed to the ground by 4 unknown teens near his home in Baltimore. He had witnesses say that he had lost consciousness for over 20 minutes. And by the time he got to the emergency room at Bayview, he was fairly alert and oriented with significant bruising that was more superficial than in his brain. He was admitted overnight. Next slide, please. And then discharged to my care. And so in kind of looking at his chart before he came in, I kind of thought, well, what's unique about Seth? Well, with our electronic record, a lot of this stuff comes up very easily. So Seth, although he's now 16, was born early at 34 weeks gestation, and he was rather small, a small baby. He was exposed to heroin and cocaine and had neonatal drug withdrawal symptoms the first 2 weeks of life, also treated for possible neonatal syphilis. And after 4 weeks, almost have grown into when he would have been due, he was sent home after he was able to feed and gain weight. Next slide. Past medical history was not horribly remarkable, pretty typical of children that I see. He had asthma and seafood allergy, diagnosed early in life. Remarkably, he was started on controller therapy, kind of the chronic disease approach to kind of mitigate acute flares in his asthma, and counseled very appropriately on avoidance of shellfish and seafood. And he did very well. And he had ADHD diagnosed at age 5, and had a very bright boy who was well controlled on medication until middle school kicked in. And in middle school, kids don't want to take their meds. They feel that it doesn't make them as fun as their counterparts and peers. So he came off his meds and got his second mental health diagnosis of oppositional defiant disorder. Next slide, please. This just started kind of the whole kind of progression of issues of truancy, issues of suspensions for aggressive behavior, impulse control issues towards other students, and ended with assault charges when he was 15 and placement in an alternative school. So I don't have a lot of kids coming in with ankle bracelets, but he was wearing an ankle bracelet to monitor compliance with court-ordered home detention when he was not in school. So what's amazing about this child is that he had a very involved grandmother. In addition to maintaining her full-time job to financially support the family, she was always ever present, and during visits, whether it was with me or with school meetings or other juvenile service appointments. His biological mother was very erratically and sporadically in the household, only until age 5, and her whereabouts are not known, as is his father's whereabouts. We believe he's incarcerated at this time for selling drugs. At a young age, Seth became sexually active with high-risk behavior without condom use. And although he denies illicit drug use, he does say that he smokes some cigarettes. And, his teachers, he's kind of a lovable guy. His teachers, aside from his impulse control issues, say that he's a bright but very unmotivated young man. Next slide, please. So I'll go through this rather quickly because Jackie and Amaka did such a good job, but I think what we need to get at is kind of what Nelson Mandela said. We need to see that poverty, kind of disparities, and often the causes of disparities are, they're inequitable differences. that are potentially systematic and avoidable and can be removed. So when we look at the lifespan model, we have to take into account everything, not only the biologic, but the psychosocial, the socioeconomic perspective. And, even looking at these different perspectives may help to inform some of the resiliency factors of why children in these environments go on to not have such poor outcomes. Next slide, please. So the focus on this perspective across multiple stages. Some people even think of the health of the child or the adolescent as an intermediate outcome that is part of a much bigger lifespan context. So some very interesting studies have shown that there may be critical periods or sensitive periods during one's life when a given exposure may have a permanent influence on later life. And one of these investigators from the UK, who unfortunately has since passed away last summer, was Dr. David Barker, for which the Barker hypothesis has been named. And he identified fetal development as one of the critical periods, that the conditions that occur during pregnancy can have tremendously long-term effects on adult health. Next slide, please. He found that babies born lighter in weight or small for gestational age, as our patient was, appear to have increased rates of all-cause mortality. And specifically, they have very high rates of cardiovascular and obstructive pulmonary disease mortality than their counterparts who are born at normal or slightly higher weight. And the thinking is that if a mother has an inadequate diet, then it signals to the baby in the intrauterine environment that this living condition in the long term will probably also be impoverished. Consequently, the baby adapts by changing its body size and metabolism with the harsh conditions of food shortages and adversity after birth. And then there are physiologic and metabolic processes in the body that undergo long-term changes as a result of this intrauterine restricted environment. And a lot of investigating is now looking at the turning on and off of genes and the interaction of these genetic risk factors that occur in this harsh intrauterine environment. So the next slide, I'm not going to kind of really look more at, so this is a slide that looks more at socioeconomic conditions affecting adult health outcomes. So, again, children, as Amaka had said, risks accumulate over time, over one's life course. And early adversity causes biological differences. It seems that these biological changes, for a better word, get under your skin. They're embedded. They are not just transient. They leave a mark on the physiology and psychology of the child, and the change persists through life. So we can look here again with socioeconomic adversity. We can see similar mortality in the cardiovascular and respiratory arena, but we also see it behaviorally, as many of us know, through alcohol, substance use, and smoking. We see it also in periodontal disease, a huge disease in this country, self-rated health limitations and functional limitations, and in depression. Next slide, please. So when we look at that, we can see over his lifespan that he had a very rough prenatal environment. He was exposed to significant stressors, exposed to poverty, exposed to drugs. I don't have a lot of information about his maternal nutrition or his mother's access to health care, which is also a huge determinant of outcome. But we can look in this this embedding phenomenon postnatally. Poverty is a huge risk factor for premature birth, developmental problems that ensue in the premature population, chronic lung disease, asthma risk is much higher. For nutrition, food insecurity, not always failure to thrive, sometimes obesity as the outcome. Poor educational outcomes, lower academic achievement, lower rates of graduation, and we could see kind of already in Seth at 15 or 16 years of age, he's got potentially the diagnosis of 2 to 3 mental health diagnoses that, unless there's some kind of change in course, are going to lead to kind of more profound criminal behavior more than likely, and lower productivity, and ongoing the intergenerational cycle of poverty. We can also look at kind of some of the protective factors, that he has a very nurturing extended family. He is academically bright and his teachers believe in him, but it's very hard for him to stay in the environment that can nurture him the best. Next slide, please. So this is my final slide. So what can we all do? It's daunting. I think getting to the point where we understand the community where our children live, learn, and play is critical. We at all levels need to screen for and identify health disparities related to poverty, food insecurity, domestic violence, toxic exposures. We need to identify some of the unmet needs and barriers, not only medical, but social, emotional, and cultural. We can't do it alone. Kind of what's wonderful about this kind of conference is that we can identify partners and resources in the communities. I'm not going to read all those, and we can look at our own. I think what's very interesting is pediatricians by nature are fairly empathetic and accepting, but we bring our own biases to the table. I find myself saying sometimes, oh, it's just so inevitable as I throw my hands up. So I think we need to be reflective. And as Nelson Mandela so beautifully put, was quoted, and I'd like to quote Frederick Douglass, a Marylander, a former slave, an abolitionist, and a dazzling orator. And in the mid-1880s, Frederick Douglass said, "It is easier to build strong children than to repair broken men." So I'm, with that, going to send it back to Cheri.
Great. Thank you very much, Dr. Fertsch. That was excellent.
Thank you.
And now I'd like to turn the presentation over to our colleagues at Advocates for Children and Youth, Leigh Cobb, Passarella, and Neha Trivedi.
Thank you, Cheri, and to everyone. This has been a terrific start to the webinar. And I will be shortly turning the program over to Passarella, who is our research coordinator, or as known in the office as our data guru, and Neha Trivedi, our senior health policy associate. But first, I wanted to tell you a little bit about ACY. If we go to the next slide, please. ACY is an independent, statewide child advocacy organization that works across 4 issue areas. Next slide, please. Thank you. Those issue areas are education, child welfare, juvenile justice, and health. And in addition, our work looks at racial equity and economic sustainability. Our current health priorities include evaluating children and families' access to health coverage under the state's new eligibility and enrollment system. Some of you may have heard about glitches in that system. But we're also monitoring network adequacy for primary and pediatric specialty services, including pediatric dental care, which many of you know has been an issue here in Maryland. In addition, we're monitoring enrollment and access to health services for former foster youth who now, under the ACA, will be eligible for Medicaid up to age 22. So part of that work is identifying those youth who have aged out of the system but who are now eligible to age 26. The other thing we are looking at is identifying effective integrative care models, including health homes, to improve health status of vulnerable children and youth. And we are also collaborating across silos to address social determinants of public health. And with that, I will turn it over to Al and the next slide on some of the data.
Thank you, Leigh. Good afternoon, everyone. This is Passarella, Research Coordinator, Advocates for Children and Youth. Excuse me. We're going to start with a demographic representation of what the state looks like for the population under 18 by race ethnicity. Really quick, we chose these 9 jurisdictions because not only did they give a good geographic representation of the state of Maryland, but they also give a good locational representation as well, because we have a mix of urban, rural, and suburban counties, as well as counties and jurisdictions on the eastern shore, as well as central and western Maryland. As you can see, Baltimore City and Prince George's County, in terms of this population group, are a minority majority, with Black youth making up the largest percentage of this group. Hispanic youth are also a burgeoning population group in Montgomery, Prince George's, and Frederick counties. and Baltimore County and Somerset County both closely resemble state averages. We can go to the next slide, please.
Next slide, please.
Thank you. Here we have a map of both children living in poverty as well as uninsured children. As you can see, Maryland does have large pockets of children living in poverty, most notably Baltimore City and the eastern shore counties of Dorchester and Somerset, and that's going north to south. Additionally, much of the eastern shore and western Maryland have child poverty rates that are above the state average. With regards to uninsured children, again, the eastern shore of Maryland represents the large portion of children without health insurance coverage, as does Prince George's County. Access to resources in many parts of these mostly rural areas could, and we believe is, a contributing factor to the higher rate of uninsured children in Maryland. Next slide, please. Next slide. Thank you. Okay. Next, we look at the infant mortality rate per 1,000 live births. The highest rates of infant mortality are in Baltimore City and Prince George's County. Increasing awareness of prenatal care and access to prenatal care resources are two factors that can be attributed to the higher infant mortality rates. So efforts should be concentrated in these two areas based on highest need. As well as the LNE is a low number event, as you can see. That's less than 5 births. Next slide, please. Next, we'll be looking at child deaths and teen deaths in Maryland. The total number of child deaths are highest in Baltimore City and Montgomery County, with significant numbers occurring in Prince George's County and in Baltimore County. Additionally, when we look at teen deaths, the total number of teen deaths are highest in Baltimore City and Prince George's County. And one factor in particular for Baltimore City and Prince George's County is homicides are a significant factor in those two jurisdictions. Total youth homicides in Maryland from those two jurisdictions represent 63% of the total for the state. So they are definitely a contributing factor with regards to teen deaths in both Prince George's County and Baltimore City. The next slide, please, and thank you. Next, we're looking at low birth weight babies and teen birth rate. So when we look at low birth weight, we have the highest rate in Kent County on the eastern shore, as well as in Prince George's, Charles, and Caroline counties, as well as Baltimore City. Limited access to prenatal care is also one of the largest contributing factors to low birth weight babies. So efforts to increase access to resources and awareness of the importance of prenatal care would be helpful and targeted in these areas. The teen birth rate is highest in Baltimore City and in Dorchester County, which conversely are two of the counties with higher rates of children living in poverty in Maryland. Access to contraception and contraception education would be would help to greatly reduce the number of teen birth rates in these areas. And next, I'm going to turn it over to Neha Trivedi, and she will finish the rest of the data slides for us. Neha.
Thanks, Al. Good afternoon, everyone. My name is Neha Trivedi. I'm the Senior Health Policy Associate here at ACY. Next slide, please. Thank you. Another resource we found helpful when looking for health indicators that affect child well-being was the Maryland Medicaid eHealth Statistics website. It was provided by the Hilltop Institute at the University of Maryland, Baltimore City, and DHMH. The next few indicators I will be talking about will be specific to the Medicaid population in these specific counties here in Maryland. As you can see, Baltimore City and Baltimore County have a higher percentage of services used for ADHD and ADD among children ages 6 to 13. We found that among this different age ranges here in Maryland, this population had the highest prevalence of services utilized. Though there's no one test to diagnose ADHD and ADD in children, diagnoses can be made based on observation and behavioral patterns among youth. This can hint to why the higher percentage in Baltimore City and Baltimore County could have been made through schools. Next slide, please. For the purpose of this next indicator, substance abuse is defined as alcohol and illicit drug use. Here you can see that the average for Maryland Medicaid recipients with services for substance abuse is around 22%. Most counties hover around the average except for Montgomery County, which is at almost 40% of services utilized. Montgomery County has been shown to be the third highest marijuana and illicit drug use and the highest number of cocaine users by the age group of 12 to 17-year-olds from all the jurisdictions in Maryland, which can portray why this county may have a higher percentage for these services. Next slide, please. The next indicator we looked at was tobacco abuse among ages 14 to 20. Maryland has an overall low average of services for tobacco users among youth in this age range. However, Prince George's County has a significant spike in services utilized. Studies have shown that youth start experimenting with tobacco earlier in middle school and high school in this county, therefore utilizing services at a higher rate. In recent news last week, CVS Pharmacy decided to pull cigarettes and other tobacco products from stores starting October of this year, which has been a big success for health advocates, and we hope that this will help reduce services used among other counties in Maryland as well. Next slide, please. Studies have shown that Medicaid enrollees have a higher chance of experiencing depression than those with private employer-based coverages. You can see here that Prince George's County has the highest percentages of services used for depression among the same age range of 14 to 20-year-olds. This percentage mirrors those services used for tobacco use among this population, as studies have shown a high correlation between tobacco use and higher depression scores. Next slide, please. The next indicator we looked at was asthma for ages 6 to 13. Asthma service utilization in Maryland for Medicaid recipients are an average near about 30%. There are many factors that can contribute to asthma rates in specific counties. For example, in Montgomery County, there is a higher rate of percentages for services used, and there has been solid research that shows home visiting programs make a difference in prevention of asthma among youth. For example, Baltimore City Health Department has a pilot program that provides home visiting programs, which has shown to be an evidence-based program. It has 6 sessions for home visiting and includes sessions for families and children for those people who have persistent asthma. Outcomes show that there have been fewer hospitalizations and fewer emergency room visits in Baltimore City. Next slide, please. The next few indicators I'll be talking about were found through the State Health Improvement Process measures through the DHMH website. They have 39 total critical health measures, and the following pertain to child health. The rates of blood lead levels are decreasing in Maryland, and as you can see, the average percentage of children tested who have blood lead levels greater than 10 micrograms of lead per deciliter of blood is 0.35%. Baltimore City and Allegheny County do have a significantly higher percentage of children who tested with higher blood lead levels. This can be caused by multiple factors, specifically neighborhood and housing developments, which contain lead paint that can be found in homes cause these high blood lead levels. Next slide, please. As defined by the SHIP indicator, child maltreatment is child abuse or neglect that can result in physical harm, developmental delays, behavioral problems, or death. abused and neglected children are at greater risk than others for delinquency and mistreatment of their own children in the future. Here you can see that rates for children who are maltreated in Maryland on average is low. However, Allegheny County has a rate that seems to be quite high. This is due to a methodological formula that was used to be consistent for all of the counties and jurisdictions in Maryland. The DHMH Vital Statistics Administration conducted a review of referrals received, cases assigned, and investigation results, which didn't really indicate an unduly high rate of reported child maltreatment in Allegheny County, which shows why in the Allegheny County rate may be higher than expected. Next slide, please. We also looked at the percentage of students who graduate high school in 4 years in Maryland. On average, the percentage was around 84% for Maryland. Most counties hovered at the average or above, except for Baltimore City and Prince George's City, which conversely shows that these are the two lowest performing school districts in the state. Next slide, please. The next indicator we looked at was percentage of children receiving dental care. Spurred by Diamante Driver's tragic death in 2007, Maryland has initiated many reforms to address dental access for low-income children. In 2011, the average percent of children receiving dental care was around 60%, which has been a big improvement since 2007, where it was around 30%. In addition, since 2008, there have been 1,000 additional dentists that have been credited as Medicaid providers in Maryland. There has been an increase in dental rates as well for our 2015 budget. But the combined state and federal increase in amount wasn't as much as our increase received in 2008. So we hope to keep our efforts and our work in dental care prominent to allow more percentage of children to receive dental care in the future. Next slide, please. This is our final slide. Here you can see a map of Maryland comparing the percent of obesity in low-income preschoolers versus adults. Here you can see that there's a high prevalence of obesity for preschoolers in Montgomery County, and for adults, there's a high prevalence in Baltimore City and in Southern Maryland. There's been a lot of research, and there's been a recent campaign advertisement that has been brought up on TV with the Horizon Foundation that partnered with Howard County to launch an ad to help fight childhood obesity. The ad promoted healthier beverage consumption and lowering the amount of consumption for sugary beverages. The efforts were to show on TV and have a campaign around Baltimore region for children and adults to lower their consumption to prevent obesity in this population. And that's our final slide. The next slide has our contact information, and thank you.
Great, thank you. Thank you to Leigh, Al, and Neha for that great presentation. And now we're going to open up the webinar for Q&A, and we've received a number of questions. This is great, and you can keep those questions coming. And I'm going to put these questions out to our presenters, and hopefully they'll be able to answer your questions. So the first question we have is, do we need more school-based health staff, such as nurses, as well as community health workers to do home visits? So which presenter wanted to take that question?
Well, this is Leigh Cobb. I'm happy to start. Others may have something to add. The answer to that is certainly a resounding yes. I think there's an incredible need to use school-based health centers to also improve access to oral health care. And one of the issues has become for kids who are identified through screening in schools, how do they then get to a dentist? And so there is a case management potential component that nurses in school-based health centers could play. I also really think there's, I think others would agree that home visiting is incredibly important, both in terms of reducing poor birth outcomes and postpartum care and support for moms, but also that the link with asthma prevention is really strong, and it's something I'd really like to see Maryland move forward on. Other thoughts?
Great, thanks, Leigh. Any other thoughts? Okay, great. The next question is, what do you think would be the best assistance for children who are showing behavioral problems at home as well as at school?
This is Diana Fertsch. I can start to address that. I mean, I appreciate the broadness of the question. I think it speaks to the challenges that families face when they're kind of at the end of their rope and their child is either, kind of showing academic or behavioral problems. The traditional model has been that, pediatricians have not been in this arena much. But I kind of would say the leadership of the Academy of Pediatrics and has really taken a stand that pediatricians need to be in this arena. And this is kind of has occurred over probably a 10 or 20-year cycle now. We don't have enough mental health professionals in Maryland to see all the kids who are going to have challenges in behavioral and potentially academic issues at home and school. So pediatricians, I would say, would be the first line kind of entry point. And, pediatricians are getting more training in residency and post-residency training. There's a wonderful initiative through funding through Dr. Wisso, who has worked out a program called BHIP, B-H-I-P-P. It is a state-funded program that provides actual real-time support to pediatricians who may be sitting with a complicated patient with mental health issues in their office. And it's kind of like if you have a phone, you have a psychiatrist. So you can actually call into this line and within hopefully real time, but sometimes it takes less than a day, you'll get some much needed coaching and support and connectivity to resources. So, I think we, as pediatricians, at different levels, we really need to reinvent ourselves. We need to be partners with the population that we serve, not just the medical being that's sitting with us. We really need to coordinate and communicate across different disciplines, looking at all the factors. So I would say pediatricians are a great place to start. Obviously, the schools are taking a yeoman's part of the work as well with student support teams. But that would be a good partnership to start if you have a good relationship with your pediatrician.
Great, thank you.
Can I add,
our next question. Oh, yes.
Sorry, this is Amaka. I just wanted to add two things for that, Leigh. I think that's excellent for people to remember the partnerships that we have in pediatricians and also to be advocates for the youth that we either care for or work in concert with, just to increase our resource pool in terms of understanding and knowing the resources of either persons or organizations available to us in our agencies, but also within our counties and within the state as well. So I think we all probably have desktop resources, and it's sad to admit that maybe some of them are years old. So updating those resources and being in contact with persons on a regular basis in case those resources need to actually be followed up on. Thanks.
That's great. Thank you, Amaka. So we have a few more questions here. One of the questions is from Jeffrey Rosenthal, and it's regarding the data. So this would be for Al and or Neha. The question is, what accounts for the high rate of child death in Montgomery County?
This is Al Passarella. With regards to Montgomery County's high rate of child death, I haven't really explored. Most of my focus has been involved in Baltimore County, and I haven't really explored Montgomery County's child death issue at this point in time.
I think that this is Leigh Cobb. I think at least there is some concerted efforts in Montgomery County around drinking and driving, because I think that some of it was attributed to that, although I think those drinking and driving rates are down. So it's often very hard to tease out what is accounting for the overall rate.
Additionally, Montgomery County is seeing an influx of a larger influx of immigration into the county, and with that, it's oftentimes lower income. So you're starting to see a lot of the same effects that you see in high poverty areas, such as Baltimore City and in parts of the Eastern Shore, are kind of working their way into Montgomery County as well. But that's certainly an area that, as we move forward, Neha and I are going to do a little more exploring into.
Great. Thank you, Al and Leigh. We have another question. This one is regarding home visitations in Baltimore County. Do you know if any of your staff or home visitors have experienced any barriers when presenting the reason for a home visit? The person posing the question currently works in a similar field as a community health worker and would like more information.
Can anyone specifically address that? ACY does not do direct services, and I'd love to get feedback. I must admit I'm more familiar with home visiting programs here in Baltimore City.
I can talk a little bit about that in my practice in Dundalk. So, you know, very recently we use a form that kind of is triggered when someone kind of fails the screening tool. And we also, for all children that spend any time in the NICU or have any prematurity or maternal drug use or depression, you know, we have very high, very low threshold for referral to infant and toddlers. And I have a number of families that are tremendously suspicious that you're going to kind of engage the social services CPS is kind of what they're worried about, and that this is going to kind of be kind of this, frictional type engagement and not something that's supportive. So, I share with them kind of, my model of your brain is kind of like your body and your potential is like Jell-O. You want to get intervention early. It's kind of an old Head Start poster before the Jell-O sets. And I share with them that babies who are drug exposed often have developmental delays, and if we wait till they're 2 or 3, where they might be eligible for early childhood services in schools, we've missed the boat, and that the people that come out through these services for infant and toddlers are not there to judge them. And if that happens, they should let me know, but are there really to support and to help monitor the progression and normal development that we want for their child. Many of them are very guilty about their behavior or are worried about kind of this, this whole, what are they going to think of me? They look at where I live and the chaos in my home. And I say, listen, we all, they see a lot worse. So, invite them in, create a relationship, and let's take it from there. And I sometimes have to, again, follow up a few times and get, kind of hear their concerns, to listen through that, kind of that just feeling discriminated, feeling bad, feeling, kind of, bad about the choices they've made that has their child be at risk.
Great.
So I think sometimes partnering with a pediatrician, if you have a family that you really feels needs services, can help to kind of set the stage for a more positive interaction.
Great, thank you, Dr. Fertsch. So we have a question from Deborah Jackson. I think this is a great question. It is, there's resistance to medication for ADHD, especially from some cultures where there are alternatives. Are there ways to educate parents from a culturally sensitive perspective on medications or on alternative practices to help with ADHD?
I'm sorry to monopolize, but I kind of one of my delights in my day is to take care of kids with ADHD. I think they're phenomenally gifted kids who are, kind of horribly misunderstood, and so there's some great resources. So there is a organization called CHADD, CHADD.org, which is a advocacy organization and does not endorse one modality over another, but really tries to provide, kind of evidence-based interventions that work. And there's a lot of alternative. I think you have to kind of, again, when you're kind of having that dialogue, if someone is really not interested in meds, I think they need to then kind of look at the data of what is most important for them. What are they willing to do? What have they, the behavioral interventions? And sometimes they're willing to work on sleep, and they're willing to work on exercise, and they may be even willing to give their child a omega-3 fatty acid, which has some utility. So again, there are resources. I think the challenge is, this is, as with anything, you can look at asthma care. When we come at it with this dialogue of the old, the kind of Marcus Welby, I'm the doctor, do what I say, or else go find somewhere else to, go take your business elsewhere. I mean, that model doesn't work anymore. We need to negotiate. We need to sometimes, over time develop the relationship. I have a lot of families that come in and they're very clear that medicine is nothing they want to go near. Some of them from a cultural perspective, other ones from a historical perspective of someone in their family who had a negative reaction on medication. But so I engage them to go to get some support through this CHADD network. CHADD of Maryland has I think 6 or 7 meetings per month for parents, for adults, and for some speaker meetings in Cockeysville. So if you just get on the chadd.org site, there's some really great advocacy and support information available. I'm happy to provide that. We've talked about doing, as we were just talking about, generating kind of these resource lists. I think it's very important to kind of have current resources, because some of these things have been around for, as CHADD has, 26 years, and they're amazingly effective.
Great. Thank you, Dr. Fertsch. And I wanted to end with a question to the panel. That's from Jeffrey Rosenthal. This is, what single public health intervention would you recommend to have the greatest favorable impact on addressing pediatric health disparities in Maryland?
This is Jackie Dougé. I'd say, health insurance is first and foremost. The issue is that, most kids are insured either through, parents who have employer-based insurance, or now with the Maryland Health Connection, the expansion of the exchanges and expansion of Medicaid for parents. But unfortunately, there still are going to be children who are not, because of, residency status, are not going to be covered. And as long as they're not covered, then a lot of services are going to be, limited, or in some cases out of their reach. And I think providing, equitable access to health care is one way I think that would help provide a link and hope for kids.
Great, thank you, Dr. Dougé.
This is Amaka.
Do any of the other panelists?
So this is Amaka. I'll chime in. I was going to echo Jackie a bit, but I think the next one I would say is to have some level of engagement with community. I don't know what agencies or facilities or institutions those on the call represent, but just having a way to engage with community, get their feedback, and hearing honest and open discussion about their challenges and their needs. And I think sometimes we lose that, or make assumptions over and above maybe the group and through isolated discussions. And so ensuring that we're not just still hobnobbing around tables, and that we actually have a good substantial reach into the community for back and forth, for discourse, not just giving information but also receiving it to improve our services.
Great, thank you, Amaka. Anyone else like to contribute?
Diana, you want to go first?
Well, I would just say, I kind of often sit here and I go, if not me, then who else? So it ultimately comes from this, this notion that, there's almost like, I grew up in kind of a family where everything's possible as long as you have a committed listener, you're in relationship. I think to see this as not a hopeless situation, but there are things that we can all do that then build skills and get us turned on, and then take on the bigger challenge, I mean, I think many of us on this call, 100 or so, have been fighting the good fight, and we're still fighting it. And so make our voices known, kind of use our leverage in whatever arena we have to kind of, just state the case and, help the people we serve.
And just to add one more thought, I was sort of thinking of building on both what Amaka and Jackie said, in that I do think access to healthcare coverage is absolutely essential. We know the current system doesn't cover everyone, so the safety net is incredibly important. But we also know that having an insurance card does not guarantee access. And I think we have to make sure that networks are adequate, both for the MCOs and for the insurance providers, that there are a sufficient number of specialists and those who deal with children, including dentists, many general dentists that really do not want to see children under 7 or 8, and the Maryland Dental Action Coalition has been doing some training around that, which is good. But I think really understanding the access issues is important, and I think Amaka's comments about engaging the community really are a piece of that. I think integrated care models are incredibly important. So someone is not looking at, and Diana's practice seems exceptional in this respect, but it's easy for a medical provider to just look at the medical aspects of the children, particularly with time constraints. And it is really important to have a broader picture of the children, of the family, to engage the family in the child's care. And where possible, I think home visiting programs can really add to the dialogue. I think both for the provider, the community health providers, understanding of the family and the medical needs of the family are so enhanced by community health visits. So expanding home visiting per se, but also expanding community health workers, and really relying on people in communities as a resource to reach out and engage family.
Great. Thank you, Leigh. So I wanted to thank everyone for participating today, especially all of today's panelists. And for all of our participants, please be on the lookout for an email where there will be a link to the webinar recording to share with your colleagues if they were unable to participate, as well as a link to the webinar slides. We also will be sending out a post-webinar evaluation. We hope that this is the first in a series of webinars addressing these topics. This one really began with the data to introduce the topic, but we're very much interested in hearing what topics in pediatric health disparities you are interested in, so that we can then find the appropriate speakers so we can try to educate as many people as possible about those issues. So with that, I thank everyone for participating. Enjoy the rest of your afternoon.
Thank you.
Thank you.
Thank you.